Welcome. Are we ready to go? Wonderful. Well, thank you for joining us. My name is Cliff Megerian, and I'm the president of the University Hospitals Health Systems. And we're going to have, I think, a very informative and helpful session today about how COVID may affect families and children. And I'm joined by someone who is a good friend and a great colleague, and somebody who I think is going to help us really answer a lot of very important questions. Patricia DePompei is the president of Rainbow Babies and Children's Hospital and MacDonald's Women's Services. And she may or may not know this. We actually started at UH about the same time. I came here in 1988 as a surgical intern, and you started as a pediatric intensive care nurse in '89.
Correct.
Right? And
yes.
Then in 2012, she was named to her presidency, and we all know the tremendous success and growth of Rainbow, including the Rainbow Center for Women and Children's recently, which was her brainchild, and obviously happened with the help of the donor community, many of whom are on this webcast. And then last year, she was named and honored as the inaugural chair of the Rainbow Babies and Children's Hospitals Distinguished Chair in Innovation and Excellence. And I think it's really exciting that our CEO of our children's hospital has been bestowed a chair. But remember, she's a clinician at heart, and I think that's something that helps, I think, define the way that she has been able to establish the excellence in leadership at Rainbow. What I wanted to do is just briefly go over some of the current trends as it relates to COVID in Ohio, and then we will open up for questions after Patty's opening remarks. But in brief, as you know, Ohio fortunately has been, if you will, given a lighter version of some of the COVID injury, if you will, that has affected parts of the country, such as in New York, such as in New Orleans, Detroit, Los Angeles. Nevertheless, Ohio has responded very carefully, I think, responsibly after the March 9th order of our governor to, if you will, shut down elective procedures and move predominantly to virtual health in terms of connectivity. We, as an organization, back when we didn't know exactly what was going to happen in terms of the totality of cases that affect our organization, we were advised to be able to manage a 300% increase in COVID patients to our normal platform. Our platform is about 1,700 licensed beds throughout the system. And so therefore we were obligated, and Patty was in charge on the pediatric side, to make sure we had the ability to take care of over 5,000 COVID patients. The good news is during the peak, we had at the most intense amount of patients in our system, we had less than 100 patients. And the good news is those numbers are going down. Around Ohio is stable, meaning that it has not seen a significant or any notable increase since there's been loosening of some of the rules around restaurant use, gym use, et cetera. That's a good sign. I'll have to say that we are seeing an uptick in areas where there's communal living situations, particularly in nursing homes, in prisons. We have been asked, and we responded very quickly to the governor's request to begin adopting nursing homes to start doing testing and managing some of their folks, and that has been a big part of some of the folks that we're seeing. So with that being said, I think overall good news in terms of the COVID situation in Ohio. And here, I'd like to turn it over to Patty to perhaps give us some opening remarks and thoughts about how this affects children and families.
Sure. Thank you, Cliff. And good morning, everyone. And again, we want to thank you for your incredible support. You've all been amazing supporters to University Hospitals, to Rainbow as well. And we couldn't do it without you. And I mean that sincerely. The good news is, as it relates to coronavirus and children, we learned a lot from the experiences in Italy and China. And at that point, it was felt that coronavirus luckily had seemed to have spared children, in that they weren't requiring hospital admissions at the rate that adults were. And so the focus here in the United States was really on creating the opportunity for children not to spread the virus, because there was great concern that potentially children could be asymptomatic spreaders. So as Dr. Megerian indicated, Governor DeWine's orders relative to school closures and daycare closures were exactly around that, to try to limit the spread. We've known, and in fact, across University Hospital's health system, our experience with children has been that luckily they have been spared. Out of over 25,000 COVID tests that occurred as of yesterday, I checked, less than 100 positive tests were in either young adults or children under the age of 20. So that's a really relatively low rate. Likewise, in pregnant women, there was great concern because pregnancy can be such a time of joy, but it's also a time of stress, particularly when there was decreased visitation. We've seen relatively low rates of COVID positive women. For women who are asymptomatic, only 1% have tested COVID positive. For women who present at the time of delivery in a symptomatic state, about 14% of them are COVID positive. But again, relatively low numbers. I know there have been many questions relative to something new that we're seeing in children that we're going to be going into greater detail in just a moment. But again, we very much appreciate the opportunity to answer any of the questions you might have, and in many regards reassure you with what we're seeing.
Wonderful. Thank you very much. And I know that this is something that's very, very important, obviously, how our children are doing and how they're going to be able to manage things during the summer. So certainly open to questions if there may be some, or if not, we can begin talking about some important issues.
Okay,
Maisie?
let's throw out a couple of questions just to begin with, and then as they come in, we'll continue, maybe with some issues peppered in between. While COVID is rare in children, as both of you have mentioned, how has Rainbow prepared for patients?
Oh my goodness, that's a wonderful question. As Dr. Megerian indicated, the preparations across University Hospital's health system started very, very early. Back in January, we were actually gearing up. And the same is true at Rainbow and at MacDonald Women's, recognizing there were some unique differences as we care for children. One of the main differences was really being very thoughtful about limitations that we understandably needed to impose because of our need to conserve PPE or protective material for our caregivers and our patients. But we recognized little ones couldn't be without their mom and dad. So one of the key things that we did in the very beginning was very carefully tailor policies and procedures, adapt what had been done for our adult patients, and then carefully modify them for children. So that included changes in policies and procedures around visitation, around how rooms were set up. We also looked very thoughtfully across the literature and across the research to better understand clinical practices that might need to be modified for very premature babies up through young adults. And so all of those things were implemented very early. We also paid a lot of attention to the psychosocial needs of children. As children are growing rapidly, they enter different stages of development, as I know you all know so well. And so we needed to tailor our approaches to how we were managing treatments and procedures so that we didn't scare and frighten the children. And we were very, very careful about that with our wonderful child life team, who do a great job of always guiding us onto how to provide the least amount of stress to kids in the hospital environment.
Patty, may I ask a question? You know, as you're aware, on the adult side, we limited visitors. Part of this was, if you will, mandates from the state, and that was challenging for our patients. How difficult was it to have families, because you were very thoughtful and careful, and you realize that a baby or a child can't be by his or herself. Right. We need to have the parents there. How difficult was it to get the parents to comply, if you will, with the masking and the hand washing and the social distancing that was required if they were going to be accompanying their child? Was it pretty easy? People complied, or was it harder?
No, I'm a firm believer for the most part, and we all know it, parents want what's best for their baby and child. So whenever someone isn't complying with something, to me, it always means they don't understand it. They don't have the information. And what we have found with very, very careful, tailored explanation of why we were implementing certain things, our parents were really compliant. we're all human. Every now and then we forget. And unfortunately, we know out in the broader community, there's been lots of dispute about, for example, mask wearing. So understandably, visitors can also be confused.
I see.
But when we reassure them and provide them the detail, they really follow suit.
People have been asking for a few weeks now as the state begins to open up, when UH will open up a little more as it pertains to visitors. Do you anticipate changes in the near future where that's concerned?
We do. I think that one of the things that we're starting to see, I think the state is being very thoughtful and careful about the sequence of events in opening. And let's just briefly review them. And each of them requires a successful implementation, and then the next, if you will, iteration is the next step of opening. So you asked about visitors. I think the first step, which was done very, very well, was the governor and the Department of Health allowing for, on May 1st, that non-essential surgeries that can be done as an outpatient, so you don't enter the hospital, you stay in the outpatient surgical area, that those can begin. That was done with two things, because I think we all lobbied that there were a lot of people who need care who weren't getting it. But number two, it was done as a standalone implementation so that we can see over the course of a week or so how that goes, and that we're not going to see an uptick in new cases by virtue of that. The next step was to allow for folks to see their doctor in person, which previously before that, on May 6th or so, was only online, if you will, telemedicine. That's going well. I think the next step, probably before we open the door to more visitors, will be the state allowing us to do inpatient surgeries to see how that goes and whether we're able to manage proper masking, proper hand washing of all the people who come. And then I think finally what'll come after that is liberalizing the precautions around limiting visitors to adult patients. As we know, we're having parents come for children, but we're limiting visitors. And the good news is we're thoughtful, we're caring. We create special dispensation when it's important and when people need to get to see a loved one. But in terms of opening that door, I think it's going to come after the state is confident that by opening the essential parts of medical activity, that being the surgeries and the clinics, that's not going to cause another uptick. Once they're confident with that, I think will allow for us to have more. So I would say middle end of June, hopefully.
And Cliff and Macy, if I might, because the number one question I get, particularly from the grandparents in the audience, is their daughter or their son's wife is going to have a baby. And there's understandably such joy when a baby is born and people want to be able to participate. At this time, we're definitely allowing the husband, the partner, to accompany his or her spouse for the delivery of a baby. But outside of that, we're still limiting extended family members exactly for the reasons that Dr. Megerian indicated.
You know, Patty, now that you mention that, there are creative ways that families can connect with their families outside of the walls of UH, and we are definitely discovering those right now, correct?
Oh, absolutely. I'm so proud of our team. And actually, I personally experienced that when my father was hospitalized recently within the health system. And the UH team have done just an extraordinary job of trying to ensure that families feel connected. Thank goodness for FaceTime. Thank goodness for our iPads that we can use. It really provides the ability for families to connect with their loved one, even though they can't be here physically. And again, our team across the health system have done just such an extraordinary job of ensuring that.
I heard an amazing story. I was touring one of our hospitals, and I was on the wards, and this was not even a COVID ward. This was a med-surg floor. And one of the nurses was telling me that routinely what will happen is the adult patient who's in the hospital, they know to pack their cell phone or their iPhone, but they don't remember necessarily to bring a charger, and their batteries run out. And what is happening is the nurses are almost taking a maternalistic approach or a paternalistic approach, depending upon, and actually happily having the patients use their iPhones
Yeah.
so that they can connect to their family and loved ones. And sometimes when the person can't even dial, they'll do that. And they're actually taking that and feeling that's part of their job to help the patient feel whole and comforted. And it's really incredible how we've seen during this crisis a real significant, true definition of what makes UH so special.
Absolutely.
It is all the extra things that the doctors, the nurses, the staff, the cafeteria workers will do to give of themselves to help folks, patients, families who are under increased stress to minimize that stress. And I've seen it just over and over and over again. And I think it's something that's in the DNA of the folks who work at UH, literally going back generations. So I'm so proud of the folks who work at UH. They're clearly stepping up.
Absolutely.
One of the many scary things about this novel virus is what we don't know. And while children are being less affected, there is this multi-symptom pulmonary syndrome that has arisen. What do we know about that at this point?
Well, I'll start and then I'll turn it
Sure.
over. We've known for a long time. When I was a medical student in the early 80s at the University of Michigan, we were all aware there was a fairly rare phenomenon that happened in children days to weeks after a common viral infection called Kawasaki syndrome, where there was a multi-organ inflammatory process that affected the children that was still somewhat unclear as to the etiology. And we know this novel coronavirus is a virus. And I guess it shouldn't have been that huge of a surprise that in children of a very active immune system, that sometimes it overreacts and creates an inflammatory process. And so we're now seeing this so-called Kawasaki's disease, which is a multi-system inflammatory process affecting a few of our children. And if I'm not mistaken, didn't we take care of the first such patient in Ohio?
We did. So we learn a lot from every case. And Cliff, you're absolutely right. What we've seen in children is high fever, belly pain, rash. They may have swollen hands or feet or redness in their hands or feet. All of those things may suggest something that we believe may be related to COVID, because in the case of this child, and in many cases of children across the country now who have been admitted, what is found is that despite the fact that the parents had no idea the child had COVID at one point, when we test their blood, they actually have antibodies in their bloodstream, and or they could be COVID positive. Not always, but there's a much higher percentage of kids who, when presenting with those symptoms, there appears to be a linkage to COVID. Again, very early in this disease, we're still learning. The good news is, like most things, kids tend to do very well. However, Dr. Amy Edwards, Dr. Claudia Hoyen, who are two of our pediatric infectious disease docs, really want to get out the information to encourage parents, if they're seeing those symptoms in their kids, particularly a fever that lasts 3 or 4 days and it's high, above 100.4, for example, to call your pediatrician, because we definitely want to see and evaluate the kids to ensure that they don't have something else going on.
I mean, that's really, I think it bears repeating. We're seeing a lot of children who may have had COVID but had really no symptoms. And in the few cases that we're seeing of this Kawasaki's, it is almost the only sign that they really had COVID is that they then developed this inflammatory process, which you're treating very well, by the way. So that's something, again, that we've learned. Interesting.
We're hearing from Hank, whose wife is 30 weeks pregnant and works at a daycare as a daycare director. Is it okay for her to take our 3-year-old son to work and for her to return to part-time work? What are your thoughts?
So first and foremost, Hank, congratulations. What a joyous time for you. And so you'll soon be welcoming a little one into your family. We know that when you're pregnant, you are in a relatively immunocompromised state. Not the same, for example, as someone who's being treated with chemotherapy, but a woman's body is preparing for the birth of the child, and that changes their immune status. And so we encourage, as much as possible, social distancing. When that isn't possible, masking, effective hand washing. Definitely practicing in a daycare setting could put someone at higher risk. However, thanks to Governor DeWine and Dr. Acton's tremendous leadership at the state, there are very rigorous protocols that are being put in place as daycare and childcare centers reopen, so that we know, for example, temperature checking, symptom questions for families will occur. I'm guessing masking of the children if they're over 2 years of age, et cetera, will also be in place, which really lowers the risk for everyone. But whenever there's a question, and Hank, for your wife, I would encourage, please contact your OBGYN or your midwife provider, so that he or she can guide your wife specifically. But definitely those are some general guidelines.
Tom would like to know if we have any results yet from the ARMS study.
Not yet. Thank you for that question. For those who are not aware, ARMS study is a very thoughtful approach. Actually was in part designed by one of our brilliant scientists and researchers, Dr. Ganam, whereby a particular substance could be placed or sprayed in the mouth and act as almost a force field to kill any virus that would be breathed in. The good news is that this trial is ongoing. It was funded in part by the Cleveland Foundation with $1 million, and patients are being enrolled, really not patients, but workers and people around the COVID virus are being enrolled in using this on a regular basis. Obviously, it's going to take some time because we have to obviously see how many people who use this didn't get COVID. And so we have to have enough people enrolled who work around the COVID patients with enough placebo so that we can differentiate between the two. But the good news, it's ongoing. We have another trial right now through Athersys with a stem cell therapy we're very, very cognizant of the fact that when people get the coronavirus, typically some of the pulmonary symptoms, most of those folks, their immune system resolves it and they have a mild to moderate symptom course and they're not really admitted to the hospital. Many people who have a more deleterious course have a tremendous inflammatory response. In other words, the own body attacks the virus, which is living in the respiratory epithelium, that being the lungs, and it's their own attack that creates a significant cytokine release, chemical inflammatory release, and their lungs get inflamed. Well, Athersys has a stem cell therapy that blocks that, and so we're beginning to now use that again in a clinical trial in patients who are heading toward a bad outcome. And so again, I think we've talked about this in other settings. If you look at what UH has been able to do, not only to properly prepare with PPE, not only to properly be able to set up the first successful testing system in the community with drive-throughs, and then develop its own in-house testing capabilities with PCR, with Dr. Schmatzer taking the lead. It has also been participating, in fact, leading in the efforts to find effective treatments. I'll remind everybody that we were site 001. In other words, the first site in the United States to be given permission to test remdesivir, which is antiviral therapy, which based on some of our work recently published in the New England Journal of Medicine showed that it lowered the overall hospitalization to really sick patients from 14 days to 8 days with a moderate improvement in terms of the survivability. These sort of things, the ARMS study, the Athersys study, are all, even in our masking, we were the first to trial a new mask from a copper infused mask from a research group out of Israel, which is just like N95s, really able to filter out most of the viral particles, but unlike an N95 can be washed at home and reused. And we're using those masks over and over again. So again, I think that UH has done what it typically does. It does all the great medicine, but then it also leads from the front as it relates to research and discovery and new knowledge.
And I think the other important fact I'd like to add in terms of remdesivir, we also were able to utilize that drug on one of our little ones in the PICU. And so the strength of the system that we can care for tiny little babies to elderly individuals in the same fashion and offer the same clinical research is just wonderful.
It is wonderful, and I think we often see this give and take, whereby we see things that work in the pediatric frame, and we take pieces and parts of that in the adult frame, and similarly
Vice versa.
hijack it back the other way. And I think that has long been one of the strengths, really, of the organization.
Megan would like to continue the discussion about Kawasaki disease. Her nephew was diagnosed before they even knew about coronavirus. So she wanted to know, when you mentioned 100 patients, is that children or all together? And then she'd like to know how her nephew could now be tested to see if he has antibodies.
So note of clarification, the 100 tests that we've seen across the system were not patients per se. They were actually individuals under the age of 20 who tested COVID positive. So the vast majority of them did not need to be hospitalized. So that's the good news. In terms of Kawasaki's and what we're seeing now, we're calling this a Kawasaki-like illness. It's not the same thing. The symptoms are slightly different. So if someone had Kawasaki earlier, before COVID, as Dr. Megerian said, it could have been related to another viral illness, and we're still not sure of the methodology behind that. Know that it doesn't necessarily predispose someone for what we're seeing now. They appear to be two different issues. And then the last question, I think, related to antibody testing. And I will turn it to Cliff in terms of an update on where we stand with the ability to offer those tests.
The antibody testing has been a little bit frustrating across the country. There has been a flood of antibody tests on the open market that have been offered to hospitals and doctors' offices as viable tests for COVID. What we're coming to learn is that many of those tests are not as sensitive as they should be. In other words, many of the antibody tests that are being sold and have purported to be able to tell you whether you had or didn't have the virus are not necessarily accurate. What we have decided and what we've learned is that the best platform, in other words, the best commercially available antibody test that we have looked at in terms of sensitivity, that being be able to know accurately if someone is negative, are they truly negative, and accurately if someone is positive, are they truly positive, do these antibodies really show that they had COVID, is an Abbott antibody test that we're using mostly. But I think still we have to look with some caution because there is just a generalized concern. The good news is if you have a viral PCR test to see if you have COVID, that's pretty accurate if we use the right platform. We found the right platform to use. But the antibody testing, we're still working toward having the FDA and the CDC help determine what is the absolute best antibody test. So you've probably heard people on TV talk about this. We're saying the same thing. We're offering a test right now and using a test from Abbott Labs, but we're hoping to even improve that even further.
Sean wants to know your thoughts about putting children in masks for an entire day at school. And Patty, you probably know more than anyone how difficult it is to mask young ones.
Actually, I must say kids are so incredibly resilient and little ones running around with their parents in the hospital have adapted to masks probably better than the adults have. So I think things as a parent, depending on the age of the child, definitely explaining why the child is wearing a mask in terms that the child can understand. And then make it fun. Kids love to pick out the colors, the fabric, if there's superheroes on the mask or if there's something that's important. I think the more you can make a game out of it, in addition to being just a piece of someone's clothing, kids have adapted amazingly well.
It's good to hear. So this next question is about the death rate here in this country, so much higher than the rest of the world. And then he adds, besides the obvious, China not fully reporting. Why? Why are the numbers higher here than other parts of the world?
Yeah, I think that we have to be careful when we talk about death rates, and because, as I think the caller alluded to, death rates are based on the percentage of people who die who have the disease, and obviously the more people you test, the lower the death rate will be. We have now surpassed about, and it's tragic, 100,000 deaths in the United States, and then I think the question is why is it so much? And I think the other thing that's fascinating, if you think about it, is why is it that in certain parts of the country it is exponentially bigger than other parts of the country? So if you look at Ohio, or you look at a state right above us with 5 times the amount of cases and death rate 3 to 4 times, or number 3 to 4 times, I think a couple things are coming to bear. One is the ability of a community, and maybe there's parts of the country that didn't do this well, to socially distance. That is found to be the most important fundamental factor in preventing the spread of the disease, is being able to keep socially distant with masking and hand washing. There's parts of our country that have not had the ability to do that well. And what is the common pattern in those parts of the country? New York City, parts of New Orleans, especially after Mardi Gras and the St. Patrick's Day, were literally 1 million people in the street during and after the COVID virus was announced. And it's not a surprise, therefore, that New Orleans was a hot spot. I think the common denominator is communal living or communal congregation of folk. And I think some other countries were very able to institute, either by decree or by just common accepting of the new cultural norms, do that. And there's other parts of our country where we haven't been able to do that. Not to fault the people, but if, my son lives in New York City, and I've been on the subway with him, and the density of people living in certain parts of the country that have been hit pretty hard is a factor, because they couldn't socially distance with each other. I think those are huge, huge factors. Social distancing, the ability to, if you will, be able to keep constant social distancing is one of the fundamental, most important things.
We've already talked to Dr. Megerian about antibody testing, but there are numerous more questions. There's a lot of interest about that. Who should be tested? Where should they get tested? How do they get an order for a test? Can we just go back to that just for a little bit?
Do you want to start?
Sure. Well, I could say in terms of testing and how we're managing it within women's and children's sphere, all women who are coming to deliver a baby, for example, we now have implemented universal testing across our health system. And that's so that we can care for the mom in the best manner possible and understand anything that may complicate her delivery. It also helps us care for the baby better, and it helps us to protect the provider staff. So that's an automatic. Anyone who is undergoing a surgical procedure, we have implemented pre-surgical testing, again, for the same reasons, to protect the patient as well as to protect the team. Anyone who has symptoms that they've reviewed with their provider, their physician, their nurse practitioner, that suggest that it may be COVID, tests are ordered and implemented. And I'm trying to think what else. I may turn it to you, Cliff.
Well, I think this is an important question, because I think there's 2 tests that are in people's minds. The first test is the test, do I have the virus? Which is obviously what happens when you come in to either have a child or have surgery, or if you show up in the emergency room with symptoms of COVID, you get a viral test for the viral RNA. I think the test that you're alluding to is what's called an antibody test, which is, does the person have evidence that they have had and beat, if you will, the COVID virus, which is very consistent with how we, for example, treat and track hepatitis. So, for example, when I was a young doctor, the biggest concern back in those days, there were 2. One was AIDS, which we didn't have really any treatments. The second was hepatitis B. We all got a hepatitis vaccine, and within a couple months, I had to go get my blood test to show they had antibodies against hepatitis. That meant I was protected. The science about finding the exact antibody that proves without a doubt, and the right time to test for that antibody in humans to see if they have had the COVID and therefore are protected, it's still unclear. It's a part of the research that's happening right now. As I mentioned earlier, we do have a test which we think is fairly predictive that we're doing here, but we're first rolling that out to all of our caregivers. We've selected 10,000 caregivers in the UH, if you will, family, who are literally interacting with COVID patients all the time and testing them first to see the effectivity of this antibody test. But I believe, and I think Patty probably shares my concerns, the long-term ability to eradicate or at least make this something of the past will be the ability to mass scale up antibody testing. Because remember, either we're going to be able to get somebody's antibodies, which says they're okay, they'll never get it, either by two reasons. Either one, that they had COVID and they're over it, or two, our vaccines, which we're really working on very, very hard, will infer that immunity. So the antibody test and being able to mass, if you will, expand that is going to be probably one of the most important linchpins in finally conquering, if you will, this issue. And that work is ongoing right now, and UH is again at the lead. We are doing one of the biggest tests of vulnerable populations, which are the healthcare workers, with about 10,000 right now.
Very good. So why does the World Health Organization and CDC have different views on mask wearing? And based on the data with children, what are your thoughts about how school is actually going to look in the fall?
You know, I think there was so much confusion in the beginning relative to mask wearing, and that has confused the public as well, and rightly so, because initially there was not a lot known about coronavirus in terms of how it was spread. Was it aerosolized, for example, or was it transmitted versus contact? How readily could it be spread? There was also understandable concern about the availability of PPE. So there was initially a lot of concern that if there was a mandate, for example, to everyone to wear masks, that needed equipment for those providers, those caregivers who really needed to be wearing masks, and the immediacy of this situation wouldn't have them available was a concern. And so that created a lot of havoc early on. Our team was just meeting yesterday, and we said, you know, at the old age-old adage that our moms always taught us, or our fathers, you know, cover your mouth and nose when you sleep. There's some basic fundamental infection control principles that apply here. And so we absolutely are encouraging mask wearing whenever social distancing isn't possible. When you're going to be in a closed room, for example, for an extended period of time and you can't social distance, we believe strongly in mask wearing. I'm a firm believer that if we make masks readily available and accessible, we don't politicize them. They become part of our standard garb, if you will, until we have, as Dr. Megerian indicated, a vaccine or the ability to readily test antibodies to ensure that we have appropriate herd immunity. It will become just part of what we do. And kids, again, are so resilient. I'm confident if you find the right materials that are comfortable, if you allow the kids to individualize them, we don't make it a big deal. Then we can get through it until we have the interventions that we need to assure that we're either able to eradicate coronavirus or live with it for perpetuity, if you will.
Last week, Dr. Simon mentioned some alarming rates of children not receiving their standard vaccinations right now, parents fearing to go take their children into the doctor's offices. What is UH doing to help ensure that our community stays on track with these, and then also just their regular checkups?
Well, I think the first thing we've done is lobbied very hard at the state level to allow for in-person visits, which prior to May 5th were really not allowed. And you can imagine it's very hard to get a vaccine if you can't take your child to a pediatrician's office. So I think that was step number one, to prove that we can have in-person visits in our pediatrician's office in a safe manner with social distancing, masking, separation of people in the waiting rooms. UH has done that. We're very hopeful that combined with a fairly aggressive public service announcement cascade, whereby we are sending messages through social media, through email, through texts, and through radio ads and spots that give this message, really two messages. One, on the pediatric side, if you don't come in and you don't bring your child in, your child's going to miss out on his measles, mumps, rubella vaccine, and that's devastating as well if they get those diseases. And we're now seeing in certain parts of the country that's happening. And on the adult side, you don't come in, we have worsening of heart disease, diabetes, and complications of neurological diseases such as stroke. So what we're doing is we are really going in a surround sound, if you will, advertising campaign to implore, if you will, the parents to let them know that UH, the pediatrician's office, is safe. There's social distancing, there's hand washing. You will be safe, your child will be safe, and more importantly, they will not miss out on an important vaccine which may prevent even a more serious disease and disorder. So that's what we're doing. You probably have a couple things you may want to add.
Oh, no, it was perfect, Cliff. The one thing that I will add, and our parents and families are responding in great numbers. So I checked just before we came here with Dr. Drew Hertz, who leads our pediatric primary institute across the system. And our visits within our pediatrician office now, 80% of them are being conducted in person, with 20% of them via telehealth. Why is that important? Because as Dr. Megerian indicated, you can't get a vaccine if you're not coming in person. So clearly our families are receiving the message, but we want to continue to emphasize staying on track, on schedule with your child's vaccinations or your grandchildren's vaccination is so very important. We understand that people were understandably anxious. We understand there were some limitations in office hours and availability. As of June 1st, all of our primary pediatric care offices are fully up and functioning, so there should be absolutely no barriers. And in fact, we're seeing hundreds of children today. So those numbers are increasing, but we really want to encourage people, don't let your kids' vaccination slide.
You know, there's two, if you will, phenotypes or types of folks who, there are a small group of people who don't believe in vaccines, and that's going to be there. And, you know, we try our best to give the best information. Those folks will be there with or without COVID. But I think the biggest rise in people not getting vaccines was simply the fear of coming to the pediatrician's office, or the pediatrician's office weren't open. And we're doubling down on correcting that.
How safe is it for children to interact with their friends this summer? Do you see any activities being of particular concern versus maybe some safer activities that we should encourage them to participate in?
Sure. So, you know, kids definitely have missed the ability to interact with their friends. And we get it. That's what kids do. They love to hang with their friends and play. You know, again, there's a saying, the work of childhood is play. And so we recognize the ability to play and interact is so important from a psychosocial standpoint. However, that needs to be balanced with the reality that, again, social distancing, masking is so very important until we have the interventions that are needed. So from the ability to interact, I think there's some, you know, different absolute rules of thumb. Kids can bike ride, they can play catch, you know, assuming they're able to maintain social distance. They could play back and forth kicking a ball in the yard. They can sit on the driveway and color with chalk, again, in a socially distanced manner. They can wear masks and when possible be socially distanced and, you know, play virtual games together. The other things that we're encouraging is don't be afraid to reach out to your child's friends' parents and just establish some ground rules, you know, that you're both going to commit to checking to make sure that your child feels well and that you've asked them, are you feeling okay? That you're checking their temperature. It sounds crazy, but I think those extra measures of safety are so very important now, again, until we have widespread vaccinations in place. But with good caution, I think there's a way to achieve both.
So Sharon wants to know, are we sure asymptomatic people are actually shedding the virus? How much do we know about asymptomatic?
You know, I'll go back to a thought that Dr. Fauci, Anthony Fauci, who's really the head of the NIH virology activity, and you see him on TV. He really said three things really. If you have, and they did studies, and I'm going to make the numbers generalities. If you have someone who has COVID and is sick, meaning coughing, sneezing, fever, the chances of that person shedding and passing the virus is, let's say, a 10 out of 10 to someone who is within the 6-foot range. If you have someone who has the virus and has mild symptoms, maybe no fever, maybe a cough, maybe unknown that that person really has it, that person is like a 5 in terms of shedding and spreading, right? Because shedding, the question is, how much viral load does that person have? If you have someone who is essentially completely asymptomatic, has the virus, in other words, tests positive for the virus, but is asymptomatic, the chance of them spreading or shedding to the point where it matters to someone within the 6-foot range is almost a 1 out of 10. So the viral load that you have appears to be proportional to the manifestations of the systemic illness that you have. So it's not impossible for someone who's an asymptomatic carrier, because we know a lot of the spread is from asymptomatic carriers, but in terms of that spread compared to someone who is sick is lower. So that's the best answer I have, and I think that was what we've been directed from the CDC.
All right. We have another mask question, and this concerns our youngest ones with sensory issues. You might have seen some of this at Rainbow already. What is your advice? Because that makes it a little more difficult.
Yeah.
It does. So definitely any little ones under the age of 2 should not be wearing a mask because of the risk of blocking their airways, which are still so small. So definitely when we talk about mask and kids, and I should have mentioned that earlier, we're talking about kids above the age of 2. I think with any children who have sensory issues that are fearful, as always, introducing things slowly, allowing the child to participate it is going to be so very important versus for the rest of us just, plopping a mask on. That's not going to work for them. And I think anything that parents or grandparents have done to introduce new things to kids with sensory issues is going to be really important. Allowing them to touch and to feel and to explore before putting anything on their face is really, really important.
Agree.
Okay. As we begin to wrap up, I have a couple of questions because we like to give you each an opportunity to wrap up with some of your own thoughts. But I had a couple of questions for each of you. Patty, if you could tell us how our youngest ones are doing at this point in the situation, and what you've seen firsthand about how UH is helping them get through their anxiety right now. And then Dr. Megerian, could you tell us how our caregivers are doing? Because we get those questions a lot. I mean, how are they holding up? We've seen such incredible hero status stories really coming out of UH, and perhaps you could talk a little bit about that.
So from a youngest perspective, I always think children are watching us always. So how we respond to new situations, how we respond to stress, is how our children are going to relate to it. So if we view this as we should, that yes, this is a pandemic. This is something that very few of us, unless you're 100 years old, have experienced in your lifetime. And so it's all new and different to us. But I'm confident with the amazing scientific, medical expertise, the minds that are working on this, we will develop the appropriate vaccines, we will develop the appropriate treatments. And like other things that we have seen in the past, AIDS, polio, all of those issues we will get through. We need to impart that degree of confidence to our children, recognizing these are really stressful times for all of us on a personal level, on a professional level, there's so much going on. But overall, what I have seen, and again, I see it firsthand every day in the hospital, kids are watching us. If we can square our shoulders back, just model the behaviors that we're asking our kids to do, not make a big deal about it, washing hands, maintaining social distancing, wearing a mask, kids tend to follow in line just beautifully.
The question was, how do I feel our caregivers are doing? You know, as you may or may not know, the last 6 years I've been president of the physician organization, which included all of our nurse practitioners as well. So I'm keenly interested and aware of the fact that our caregivers have to be at really their best mental state if they're going to provide the best care to their patients. I think what I've seen is absolutely remarkable. I've seen a tremendous locking of arms of our physicians, our nurses, our advanced practice providers to, if you will, beat this invisible foe. And I think two things are emerging. I think our physicians are realizing that they have to be at their best to help the fears of their patients. And they are being as professional as they can, despite the extra work and the extra time, the extra stress on them. I also feel that the caregivers here come from a long line of folks at UH going back to 1918 and 1914, World War I, and then the Spanish flu, and then in 45 and World War II, who almost get energized and are functioning at their best when the stress and the call to action is before them. And I'm seeing this heroic activity now becoming commonplace amongst our caregivers. We're not naive to the fact that despite the extra work, the signs of confidence, the ability to take on the fears of their patients, despite that ability to do that, that there is obviously stress. And so we've created a program called UH4U, which is a 24/7 hotline. It provides counseling. It provides help with assets at home if someone needs it. It helps potentially with childcare. It helps basically our clinicians and caregivers get through this with additional help and what that may be. But I think the common theme, and I'm sure that Patty agrees with me, that you'll see that we have an energized workforce of caregivers who has now seized upon this event to prove that the organization and their particular individual care is better than anything that could be thrown at them from a virus.
All right, so as we wrap up, we have another question. So do we really have enough PPE? So that we can end on that.
Yeah, let me answer that question. We have gobs of PPE. That question needs to, I mean, let me just tell you, yesterday I was on the phone with Sean Osborne. We have, at the present use rate, if we didn't get another shipment of PPE in the mail, we have 1,200 days of PPE at the present consumption rate. That means we have like 3 years of masks sitting on docks and then loading docks. We have PPE. And that goes again to the amazing supply chain people we have. We have gowns. We have so many respirators that we went up from 530 respirators and added 200 more. We didn't need them, obviously, because we didn't get that. We added ECMO machines for people who fail a respirator. We added 20 more. So the good news is we are completely set with PPE right now. So that is not our concern. Our concern, and it's not really a problem, is to get our testing ability such that we could, if we had to double, triple, quadruple our ability to test, number one, the virus, and then eventually the antibody, that we're set for that, and we'll be there very, very quickly.
Again, we want to thank
we thought that was
Good job.
Good job.
Good job. We're like Good Morning America. We're like Good Morning America.
Thank you.
Well, I just want to apologize. My entrance did not distract you in any way. I'm very sorry.
Whoa.
You don't need to be. If you can't be flexible for stuff like this, shame on